what's new in the field that is rapidly evolving. The clinical and genetic variability of the disease became more understandable together with the FSHD pathophysiology. The development of new therapies for this disease is rapidly evolving, and clinical trial readiness is the core issue that needs to be addressed nowadays. The experts will give their point of view on what's new in the field and stimulate the discussion on what can still be improved with our collective effort. Sabrina Sacconi is professor of neurology at Nice University Hospital in France, that is now recognized as the reference center for rare diseases. She started practice medicine in '97 at Pavia in Italy and became a specialist in neurology in 2003. In 2004 to 2008, she began an European career and constantly improving competences and understandings on the neuromuscular disorder. In 2010, she obtained a PhD in cell physiology and biology with a work on genetic and epigenetic of facioscapulohumeral muscular dystrophy. And she's now the head of the Department Peripheral Nervous System and Muscle, and coordinates a basic research team at IRCAN, Institute of Research on Cancer and Aging, supplying several databases and biobank on rare neuromuscular diseases. Dr. Teresinha Evangelista is a board-certified neurologist and neuropathologist with long clinical and research expertise in neuromuscular disorders. She used to be the president of the Portuguese Society for the Study of Neuromuscular Diseases from 2009 to 2013. From 2012 to 2018, she was working at the Center for Life Institute of Human Genetics, Newcastle University, as a member of the coordinator team of the European Reference Network for Rare Neuromuscular Diseases, and she became now the coordinator since 2018. That was also the date she joined the Unité de Morphologie Neuromusculaire Myology Institute, Sorbonne Université, Pitié-Salpêtrière. Thank you to you both, and I would then ask Teresinha to take the floor and share her presentation, please.
Hello, good afternoon to all. And thank you for taking your time to attend this webinar. You can see in this first slide the outline of what I'm talking about. It's not that new, but it's just to refresh your memories about FSHD. So I will talk a little bit about clinical diagnosis, the diagnostic criteria, differential diagnosis, and at the end about the outcome measures for FSHD. So FSHD is a rather complex disease where we can find a continuum of phenotypes and genotypes. It's the second most frequent muscular dystrophy in adults, and the third in general. You can have asymptomatic carriers, very mild forms or very severe forms. And we have the tendency to divide it in FSHD1 and FSHD2 as if it were two different diseases. And in fact, they are a continuum of phenotypes that goes also for the genetic aspects. And we can eventually consider FSHD1 as a monogenic disorder. But we have more and more tendency to consider that this pathology, FSHD, has a lot of degenic influences and also other multifactorial influences. I have decided to make a pool that is and not we cannot identify who answers or who gives each response. Is anonymous. And my first question would be, which of the following factors do you think can influence the FSHD phenotype? Do you think it's only genetics, epigenetics, hormonal, the comorbidities, the body weight, an immunitary response, all of the above, or just 1 and 2? So please. Now it's decreasing.
Yes, people are still voting, so we have. Okay, I think we can stop now. And
okay, so most of you chose the all of the above, 53%, and some people consider only genetics and only epigenetics, and the next most voted answer was the mixture of genetics and epigenetics. Can you stop the poll, please, so that I can move the slide?
I think you can move them now, no?
Okay, so the answer to that first question, and I used some of the pictures that Sabrina very kindly gave to me, is that all of the above factors can influence the phenotype of FSHD. It goes from the genetics. We know that now that there are at least 3 genes, and there are other modifier genes that will be discovered. We know that there are epigenetic factors like the methylation, immunitary aspects. Obviously, the comorbidities will influence the FSHD phenotype, also the body weight. And well, it's well known that endocrine factors like the estrogens can influence also the phenotype. So FSHD is not a monogenic disorder. It doesn't have only genetic factors, but it's a mixture of factors that can influence how it goes. Starting with the clinical diagnosis, as I said, it's very heterogeneous. The beginning of the disease, the start of the symptoms can start at a very early age, like in this very classical picture from that was published several years ago. And we can have very late onset and also very typical forms. And more we tend to consider that FSHD is not just a disease of the muscle, and you will see afterwards, it's a multi-system disorder, and other organs besides the muscles are involved. Also of note is that, and it's important for the diagnosis, is the fact that there is an asymmetric involvement, and this is almost a hallmark of the disease. And you can see, for instance, in this picture here, that one of the legs is involved and the other isn't. And the same, there is more involvement from one side than the other. And here you can see that one side is more involved than the other. The distribution of the muscle weakness, you will know that there's a facial weakness, scapular and humeral weakness, and peroneal weakness. In these different pictures, you can see aspects of the asymmetry, like the eyelids. So it's the patients, a good way to know is to ask the patients if they sleep with the eyes open. Be aware that the fact that they don't blink as we do, and the eyes are often they sleep with the eyes open, they have tendency to keratitis, to conjunctivitis, and all that. So it's an important aspect to take care when we follow patients with FSHD. Also, they have a characteristic horizontal smile. They're unable to smile, to blow, to drink with a straw. And this is quite, sometimes it's very impacting, because people are not able to communicate with their face and communicate their emotions. Very often patients say, oh, everyone thinks that I'm hungry, that I don't like what I'm seeing, and it's not that, it's just that they cannot express their facial expression is not a normal one. Very typical, the scapular weakness and the humeral weakness, and you can see that the biceps, triceps, and the distal part of the deltoid are the muscles most affected, and this gives an aspect of Popeye forearms. So the forearms are comparatively bigger than the arms. So the peroneal weakness can be the first symptom, and it's mostly translates as a foot drop, step age, and it's responsible for falls and a lot of comorbidity in patients with FSHD if it's not taken care properly. But the other muscles can be affected. We have the traditional beaver sign that it's not specific of FSHD. You can find it in other diseases, like it was described also, for instance, in GNE myopathy, but it's a sign of abdominal weakness. The muscles, the paraspinal muscles and the abdominal muscles are highly involved, so this can give place to an hyperlordosis and the deformity of the spine, and also detent at the level of the thorax with the pectosis cavatum that we can see mostly in the most severe forms of the disease, especially in the infantile forms. When I was saying that FSHD is not just a disease of the muscles, that's why, because we can have associated symptoms that involve other organs like the retinal, like the retina, with a retinal vasculopathy, also hearing impairment. A minority of patients can have dysphagia. We can have a cardiac involvement, although it's rare, and also a CNS involvement, mainly in the infantile forms, and under the children may have epilepsy. For the retinal vasculopathy, it's also mostly present in the infantile forms, and it can be quite severe, like a Coats disease, but we can have minor changes at the level of the retina. For the hearing impairment, most studies say that it's also in the infantile forms, but we have performed a study that have shown that under the age of 40, we can find a lot of patients with late onset FSHD that also have hearing impairment, and the percentage was actually higher than the general population. I would like to take your attention over something that is not very often referred in FSHD, which is respiratory function. And it's traditionally said that respiratory function is compromised in patients with very severe forms of the disease and with a loss of mobility. Also, a study done when I was in Newcastle, we found that around 41% of people with FSHD in our cohort had reduced respiratory function. And mostly it's very important to check for sleep disordered breathing, or to check for hypoventilation, for instance, or when they are lying flat. So it's quite important to check these patients with respiratory function tests, and even with the sleep studies. Do that at the baseline and at the follow-up visits, and obviously there is a treatment which is introducing non-invasive ventilation. Pain and fatigue, often neglected in the books, in the textbooks from where we used to study the description of FSHD, are quite important in this population. Also from my previous work in Newcastle, we have assessed the pain in patients with FSHD through the FSHD registry, and we found out that around 88.6% of the patients have pain, and almost more than half reported chronic pain. And of these, 30% not only have chronic, but they have chronic and severe pain. And the places where it's more that are more affected are the shoulders and the legs and the hips. Another important aspect is the fatigue that in some studies is reported as high as 61%. And as you may imagine, someone that is permanently in a state of fatigue, it will suffer a lot of impact in his mood and also in the daily activities and in their job. So it's really important to assess these two factors when we evaluate patients with FSHD. So as you can see from what I've said before, we have infantile forms. Those infantile forms are the ones that have most of the multi-system involvement, and they are characterized by an early onset before the age of 10, also by a loss of ambulation. And here, the asymmetry that we see in the adult forms is not as frequent as we see in the adults. It's these forms that, as I said, have the pectus excavatum, they have swallowing problems, a very severe respiratory insufficiency, and all the other multi-system aspects that I've referred, like epilepsy, hearing loss, and Coats disease. We also have late onset forms, and for these late onset forms, these are somehow considered atypical forms due to the form of presentation. You don't see that much the typical shoulder involvement, but you have like a bent spine, so involvement of the paravertebral muscles. So going from the clinical aspects, this overview of the clinical aspects, I would like to discuss with you about the classification of FSHD, not just the classification in FSHD 1 or 2, but general classification, because it's really important to stratify the patients when we intend to include them in clinical trials. So as you have seen from what I've said before, FSHD is highly heterogeneous. So we need at a certain point to reach a consensus so that we can choose the best patients for the best trials. I've put two examples, one from the Italian group, which is called the Italian classification, and I'm not going through that in detail. You can find it. It's a paper from Giulia Ricci in the Journal of Neurology 2016, but basically the classification is of typical FSHD, asymptomatic, post-symptomatic FSHD, and atypical FSHD, so an FSHD with uncommon features. Then the authors go through different subcategories in either for the typical forms or for the other two forms that I'm not going to go through with you as for the sake of time. The second classification is the French classification, and I'm glad that Sabrina is here, so you have questions about this, you can ask her. And here the classification is actually more straightforward or simple than the Italian one. We have typical, atypical, asymptomatic or post-symptomatic. Also, the typical, they need at least to have two of the criteria that are considered diagnostic criteria. The atypical, they need to have at least one of the atypical criteria, with then the asymptomatic or post-symptomatic, they need to have a symptomatic diagnostic criteria and no atypical criteria. And for instance, here you could think that they can have only dominant inheritance or a slight facial weakness, because that's mostly not recognized. So this is, for me, it's a simple classification. It's fit for purpose to stratify patients, but it's not incompatible with the one from the Italian group. And I think that this should be in the future reviewed as should be discussed by the experts in FSHD. So I came to my second poll. You have heard about the clinical aspects of FSHD. You have heard about the typical and atypical forms. So my question is, what is the probable diagnosis of this patient? FSHD type 1 or 2, I don't say. It's not this one. A typical form of FSHD, the VCP-related myopathy, the Pompe disease, or other. What do you think? This is the wrong poll. You need the second one. Yeah, that's the good one. Well, a couple more of seconds. Okay. So most of you have chosen FSHD 1 and 2, or 1 or 2, followed by an atypical form of FSHD. Someone thought about Pompe. Okay, I'm closing this result. And it's actually, this slide was to take me to the next step of this talk, which is differential diagnosis. And actually, nobody got the diagnosis of this patient. She actually has another of my favorite diseases, which is a VCP-related myopathy. And this was published, and she has a common mutation. So I start from here with the differential diagnosis. Obviously, Pompe is a differential diagnosis also, but it's not the case of this patient. Okay, so some examples. So we talked about myofibrillar myopathies, but I would say that most of the scapuloperoneal syndromes are quite difficult to differentiate sometimes from FSHD, especially from the typical forms of FSHD, and especially if they don't have facial weakness. Also, some of the inflammatory muscle conditions can enter in the differential diagnosis, and obviously Pompe disease is also a differential diagnosis for FSHD. And this doesn't try to be exhaustive, but it's just to tell you that if a genetic test comes negative, and Sabrina will talk about it later, we need to think about other alternatives. And it's here that the muscle biopsy that is not at all useful to diagnose FSHD can be very useful to exclude other diagnoses. Don't forget that the dry blood spot is really easy to and not expensive, and also that the MRI can help you with all these differential diagnoses. And we come to the clinical outcome measures, and I use what is being done in the Resolve International. It's an international study that is doing natural history study for FSHD. And they're trying to compare different outcome measures that can be used either in clinic or in trials. And mostly they are divided in those clinics, those outcome measures that measure motor function or disease burden. And there are several new clinical measures that are quite interesting. So we all know about the clinical severity score and the age-related CSS. We know about the Italian scale. All this is are FSHD-COM, MFM, those are classical clinical measures. Most of them are not specific for FSHD and need to be validated for FSHD, but there are others like the IOPI that is quite important to evaluate the strength of the tongue and the lips. Also, a very interesting tool is the upper limb reachable workspace that it's really interesting for the follow-up of clinical trials. If the drug is quite effective, we can see differences in the mobility of the upper arms in a way that we cannot access only clinically. For the upper limbs, we always fall in the 6-minute walking test that is not specific. And for patients with FSHD, well, either the 6 or the 2-minute walking test are quite difficult to perform most of the times. And there is another test that is quite interesting. And in the Fulcrum trial, they have used it as an outcome measure, which is the timed up and go. Obviously, the respiratory function with the spirometry, and then all the disease burden with the falls, the quality of life, and exercise questionnaires. So these are all clinical measures that some of them are already in use in the FSHD population, but they still need a lot more of testing and proof that they are good outcome measures. And we go for the paraclinical measures in the Resolve International. Some centers use the osteodensitometry and the impedensimetry to evaluate the muscle. Also the muscle MRI, this is probably the most recognizable biomarker used for FSHD. And also, obviously, there are biological measures and other biomarkers that can be developed, and like the DUX4 expression or the determination of inflammatory pathways. So there is a lot of work to be done in what outcome measures for FSHD is concerned, and it's a good area to do some research. So with my last slide, I am passing this to Sabrina, that published a very nice paper. I don't know if she has this slide in her presentation, but I decided to put it. That really shows in this paper the continuum between FSHD1 and FSHD2 with the novelty, or not a novelty, but with the cases that are actually an overlap of FSHD1 and FSHD2. So Sabrina, up to you.
Thank you very much, Teresina, for this transition. Okay, so sorry, I'm just 2 seconds that I'm putting can you see it?
Yeah.
Yes, it's perfect.
Okay, can you hear me well? So thank you very much to Teresina and to the organizer and to everybody. Now that you know everything about my career, I'm going to introduce you on the difficult world of genetic in FSHD because it's quite complicated. And then we're going to try to go from there to the physiopathology of the disease and to talk a little bit of therapeutic strategy that are being developed. These are my disclosure. So the best definition of FSHD is that this disease is due to an effective epigenetic repression of the chromosome 4, the 4Z4 macrosatellite, leading to an aberrant re-expression of DUX4 retrogene. This gene is toxic and induce muscle atrophy and the expression of clinical phenotype. This definition, it's it's right, but it's quite complicated. So I will try to explain in more simple words. There are 2 types of FSHD that are usually distinguished, but and then we're going to see how these 2 diseases are related. The FSHD1 is the one that is diagnosed in 90% of the patients that show the typical phenotype that Teresina explained to you. This patient classically has less than 11 D4Z4 repeat on chromosome 4. The D4Z4 loss of repeat or contraction induce chromatin opening of this region, and the expression starting from the last repeated unit of DAX4. DAX4 in presence of the 4QA allele, which is a beta satellite, is become stable in its expression, because when the 4QA is present, it add polyadenylation signal to the protein, and this protein is not degraded. So in FSHD1, you will see hypomethylation of the contracted allele, the one that has lost the 4Z4 repeated unit, and you will see a DAX4 expression, and the DAX4 expression lead to clinical phenotype. The clinical phenotype of FSHD1 patient and FSHD2 is very similar in terms of distribution, the facioscapulohumeral distribution, the presence of inflammation, and also of some characteristic of multisystemic involvement. Although in FSHD2, the retinal involvement has never been described yet. But we are starting to see some atypical, some features that are characteristic of FSHD2. I'm not going to talk about that in this talk, but the two diseases are really, really similar. And also, if you are an expert clinician, and if you look at the MRI, it's very difficult to distinguish them. Why? Because they have the same physiopathological mechanism. In FSHD1, the chromatin opening of this region is due to the contraction of the 4Z4 allele, while in FSHD2 is due to a mutation in a gene that is located on chromosome 18. This gene has a very complicated name of SMCHD1, and it takes at least 10 minutes to memorize, but this gene is implicated in the stabilization of the chromatin structure of this region and of some other region of the genome. And when it's mutated, it causes a loss of the methylation. This loss of methylation is diffuse compared to the one that happened because you lose the D4Z4 repeated unit, and there is a chromatin opening and the expression of DAX4 retrogene always from the last repeated unit when this last repeated unit is 4QA. And we have then the expression of DAX4 and the clinical phenotype, as I told you. What is this gene? This gene is a gene that is implicated in chromosome condensation, cohesion, and segregation, and also in long-range chromatin interaction. SMCHD1 play a role in chromosome X inactivation, in DNA methylation in autosomal transgene, and also participate to the DNA repair during the combination, and act as a tumor suppressing gene, especially in hematopoietic cancer. This is one example of one activity of SMCHD1, which is implicated in the reparation of DNA damage. I put some example of what SMCHD1 gene do. You see, this is the D4Z4 region. SMCHD1 link to the D4Z4. When it link, it increase the methylation. It correlate with the histone and is able to pack the chromatin This is in the normal person. When you have a mutation on SMCHD1 is not able to link to the D4Z4. So it's not able to link with the histone and to compact the DNA. For this reason, you have hypomethylation, chromatin opening, and D4Z and DAX4 overexpression. And you see, since when it's mutated, both alleles are concerned, you have large hypomethylation in both alleles. But also in FSHD1, SMCHD1 has a role. Why? Because in absence of the D4Z4 contraction, SMCHD1, even if it's present and perfectly normal, is not able to link to D4Z4. So you have hypomethylation. But in this case, the hypomethylation is seen only on the allele that is lacking of D4Z4 repeated unit. You can understand why there is a continuum between these two diseases now, because you have the same physiopathological mechanism and also the length of the D4Z4 repeat on one side and the methylation of D4Z4 region on the other side create a spectrum of the disease in which there is an overlapping. In this region, between let's say 8 and 10, 11 repeat, you will find people that have FSHD1 and FSHD2 together, because you can say that the FSHD2 gene is a modifier for FSHD1. You can say also that there is a genetic threshold means that the FSHD1 have more genetic alteration, and in FSHD2 the epigenetic threshold is predominant, because this patient carrying SMCHD1 mutation have more hypomethylation. The interaction is due to the fact that when you have FSHD2 and you have a very long D4Z4 allele, you don't develop the phenotype. Example, this family in which you have the grandfather that has a late onset disease with mild involvement on the shoulder, camptocornea, and lower limb involvement. The grandfather carry a 19 D4Z4 allele and an SMCHD1 pathogenic mutation. The daughter carry the same mutation. She showed hypomethylation, but she has a longer allele of 24, and she only has increased CK and a mild adductor magnus and abdominal muscle involvement that you can see at muscle MRI. While the daughter has a pretty severe phenotype because she carried the same SMCHD1 mutation, but with a shorter allele of 12 inherited from the father, which is perfectly asymptomatic. So as you can see, the length of the D4Z4 allele, even in FSHD2, is important. And we have this length is because if the allele is shorted, as I showed you before, SMCHD1 is not able to attach to the D4Z4 allele. And so you have the additional result of the mutation in SMCHD1 and the fact that the chromatin is not compacted because SMCHD1 is not linked. And this affects both allele. Talking about physiopathology, DAX4 gene is expressed, as we said, from all the D4Z4 repeats, but the only DAX4 gene that is stable is the one that is expressed starting from the last repeat, because there is this beta satellite region that stabilizes the transcript. There are two types of DAX4. One DAX4 that is called full-length DAX4 that has the DNA binding sites because it's a nuclear factor that interacts with nuclear, and it's induce transcription of several genes. And on the other side, it interacts with target gene and activate the expression of target gene. And this one is the bad guy, the one that it's more pathogenic, while the short version is not pathogenic. So this is important to know because several therapeutic targets try to reduce full length in short length DAX4 in order to take off the toxicity of this gene. The expression of DAX4 induces the expression of several pathways. We don't know everything about this pathway, but induce genes that are expressed during germline and early development, induce gene involved in immunitary response, innate immune response, and adaptive immune response. Induce also retrotransposon gene. The retrotransposon are genes that are able to jump in the DNA and to go from one side to another one, and we don't know exactly what they do. Basically, DAX4, it's a killer gene that is expressed very early in the development, and it's a gene that is activated in different tissue when they differentiate in order to take off the cell that you don't need during differentiation. And it's, in this disease, activated by the epigenetic repression of the 4Z4 region. When it's activated, it's expressed in muscle at very low quantity and induce an inflammatory reaction. This reaction is more CD8 mediated, but there are also CD4 in the inflammation, and the inflammation, when the inflammation starts, then the muscle undergo to an atrophy. What are the targets of drug development in DAX4? There are several targets that correspond to different type of approach. Some targets are genetic and some other are non-genetic. From non-genetic approaches that are targeted by small molecule or immunotherapy, there is, for example, the hypoxia, the hypoxia pathway. There is the estrogen pathway. As Teresina said, estrogen are able to reduce the DAX4 activity because they block DAX4 in the cytoplasma, and so DAX4 is not able to go in the nucleus of the cell and is not able to induce transcription of all the gene that we talked before. And there is also this pathway, the MAP kinase P38 pathway, which is something very interesting because lead the development of a drug that is now in a clinical trial. And there are some other pathways that are being addressed on atrophy, cell cycle arrest, and myogenesis. One drug is now being tested. The name is losmapimod, and the trial is Redux trial, which is a selective P38 alpha beta mitogen, which is activated protein kinase inhibitor. It acts at this level. And we don't know exactly the mechanism, but when this pathway is inhibited, the DAX4 expression is reduced. So the drug, losmapimod, was already tested in the past in several other conditions in which it showed that it was very well tolerated, but it doesn't show efficacy. So it was not surprising that in the phase 1 trial for this drug, we have a very good result in terms of safety. Now we have the phase 2 that has been completed. We are in the extension phase, and the result will be released very soon. The main objective of this phase 2 is to demonstrate that the drug was able to reduce the expression of DAX4 in muscle, and I think it was success in this term, but now we have to understand better if this drug is useful in terms of clinical effect for our patient. Other therapy that are being tested target all this pathway. Some drug target, for example, SMCHD1 gene. The only possibility is to correct the expression of SMCHD1 by repairing the mutation with the Cas9 technology. And of course, this type of approach is limited to FSHD2 patient, and he has to be very personalized, and it's a very complicated approach because there are so many mutations in this gene, and so basically every patient have a new mutation. So a lot of approaches target DAX4 gene, either by inducing the splicing of the full length in the short length, either acting on the gene, on the mRNA. The mRNA can be targeted by several approaches, for example, with antisense oligonucleotide, but also by RNA interference technology, like it was done for the transthyretin amyloidosis, or for example, through DNA aptamer, through the introduction of protein homologous similar to DAX4, or to DNA decoy. There is also approaches that target a more downstream target by gene knockdown of the different pathway. The different pathway that are addressed are, sorry, how can I go back? Oh, sorry. Are, for example, are the pathway that are implicated in hypoxia signaling, apoptosis, immune response activation, epigenetic regulation. This is another slide that presents all the therapy that are being developed. It's amazing how in this disease the drug development is really exploding, and the work that we are doing in putting together natural history study and try to develop adapted outcome measure, it will be very important to try to bring one or more of this drug through a successful clinical trial. One of the main problems that we address in all this DAX4 target approach is the fact that DAX4 is already expressed very early in development, of the human being, and in the fetus. And the expression of DAX4 doesn't really correspond to the amount of involvement that we see in this patient. For example, in this slide of this paper that was produced by the group of Julie Dumonceau, which I have the honor of collaborate with, demonstrate that the full-length DAX4, but also all the type of DAX4, are more expressive in quadriceps muscle than in trapezius muscle. Trapezius muscle is a typical muscle that is involved very early in the disease. And so there is no correlation with the expression between the expression of the gene and the severity of the clinical involvement. So how can we explain these things? We don't know exactly. So I think we need to understand better this problem. Maybe it's due to the fact that there is the expression, but it's not the same localization of the gene. Maybe there is an important role of downstream pathway that can be different in different genetic background. For example, the inflammation or other pathway can be determined by other gene and can be different. So they may explain this discrepancy. Anyway, the better understanding of genetic, epigenetic, and physiopathological mechanism of FSHD had led to the development of several therapeutic strategies, at least in preclinical model. The main goal in drug development will be to establish the best target that can be DAX4 or some other downstream pathway, to have a drug that is safe and that is delivered correctly at the muscle that are becoming atrophic. The job of the clinician will be to try to find out what are the clinical and paraclinical outcome measures that are more sensitive to the change, to help the pharma to develop this clinical trial, and to find biomarker to measure the activity of this disease, because DAX4 is very low in the serum, is not measurable, and also the target gene. We can only measure DAX4 in the muscle, so the patient has to undergo to muscle biopsy. And several other biomarkers are being studied and developed, and in natural history study, and we are trying to coordinate at national, European, and international level all these studies in order to have the best result. And this effort is done by a lot of clinicians and researchers, and we all hope that in the future we will contribute to effective clinical trial and to increase the understanding in this very complex disease. Thank you, and if you have any question.
Thank you to you both, and this was a quite interesting communication, and it explains the complexity of the disease, and I think that we need to be more and more aligned to be able to think complex sometimes in order to solve our problems. And we don't have any Q&A question on, but if people want to put questions, you can unmute yourself. You're now allowed to talk, everybody. I will start as usual with the question of my own, because people sometimes are a bit, take a little time to have confidence to put questions. So my question is, do you think that, that's a bit for Sabrina, do you think that this is a disease that you can treat just by one of the multiple therapeutic approaches that you've done, that you've talked about, or is this a disease that in principle should need a cocktail or combination of diseases, of treatments, sorry?
I think that the answer is the second one, because of course for patients that already have lost the muscle, if you want to cure them, you need to regenerate the muscle. So at least for this reason, but also because I don't think that the approaches will be able to target perfectly the DAX4 gene. I think there will be a leak, and so a little evolution of the disease. And I think that maybe two approaches or maybe a cocktail will be the right solution in the future.
So now we have a question. Oksana, do you want to unmute yourself and voice it, or shall I read it?
Yeah, hi Antonio, hi Teresina, hi Steve. So yeah, it's just a general question. Do do you think we have something to look forward from the therapeutic perspective, or not?
Teresina, you want to? I didn't understand.
So what she's asking, if you think that there is reasonable hope behind the current therapy strategies in terms of the near future.
Yeah, so is there something on the radar that might be coming soon, or there are new ideas that look promising? So is there anything to look forward, or we're pretty much at the stage where we still can't hope for anything for a long period of time?
I think no. I think that there is this drug that is ended phase 2, and I think that it's not maybe curing completely the disease, but I think there is a reasonable hope that this drug can do something. And then there are all these approaches that are being developed by several companies. So we're gonna find something, we hope, because at least there is a really big effort that is put in FSHD, and it's really unusual because it was many years that nothing happened in terms of therapeutic strategy, and now we have so many options that are becoming available in the next future. So we hope to do a good job as a clinician, researcher, pathologist, to try to make this opportunity real for the patient.
And what would be the outcome measure that everybody's looking to improve?
Teresina, do you want to speak?
Yeah, I can. I think that outcome measures are still a difficult topic, and there's still a lot of work to be done. I think that first of all, we need to compare those that were developed for FSHD and compare them with general, for instance, for muscle strength. Compare those with the other more common ones that are used for other diseases. I really think that for certain particular aspects, there are like the reachable working space. I think it's a fantastic tool to be used in trials. But there is still a lot of work to be done. It is in the clinical outcome measures. For instance, we don't have real outcome measure for the patient-reported outcomes dedicated to FSHD. And I've seen that, for instance, Pietro Spitali is attending, and he can probably help us with the answer about the outcome measures and regarding the biomarkers, because Pietro has done some studies about this. Do you want Pietro to say something?
Well, I'm not a clinician. What I can say about biomarkers and the work that we've done on FSHD, we tried so far to look at association of genes or proteins in serum and blood to try to be as less invasive as possible to detect changes of patients compared to controls. And the work that is done in the field, but of FSHD also resembles what has been done by in other diseases and other muscular dystrophies such as Duchenne. Try to first separate healthy from disease and then see the trajectories over time of, for example, any substance we can measure in the blood to predict the trajectory, predict clinical benefit over the long run. I think for these complex diseases, it's always difficult to find over a short run a measurement that can predict, that can be associated with the immediate benefits. So I think the struggle, the difficulty, but also the aim is to try to predict clinical benefits over the long run with molecules, and I think that's where we should go also for FSHD.
Right. So clinical trials, if we're looking for a physical outcome measure for like muscle strength, it would the clinical trial would probably have to run for several years or so.
I'm not in a position, I think, to answer that, because I don't know the disease. I'm not a clinician, as I said, but I think in other diseases, I think also for FSHD, there's variability across individuals, and there's changes. They are progressive, but they are not, given the differences between individuals and the differences in trajectories, it's difficult to find in a short time frame effects that are clearly related to an improvement in a drug or an interventional trial. So the chance of improving clinical benefit in the long run, I think it's by leveraging on natural history studies. I think that's really helpful. And I think for the FDA has shown that if you have biomarkers in the trials, you have 3 times the chance of a success than trials without biomarkers. So I think that's where you have, that's why we should, I think, include them.
Yes, the stratification of the patient to one of the main effort done by the clinician is to understand the variability. So to understand the genetic, epigenetic variability, to understand the effect, for example, of body mass index, of comorbidities, and so on, in order to stratify the patient and to have less variability and better result. The second effort is to try to, this stratification will allow to reduce, to increase the sensitivity of the different clinical outcome measures. There is the MRI, which is a very promising biomarker, paraclinical biomarker, that is being developed thanks to the trial that we are doing with the losmapimod. And I think that in Paris also they are working a lot on this biomarker. And in terms of the seric biomarker, I think that this clinical stratification will be also very helpful in the development because it will allow to identify different groups. The classification done by the Italian group in different category, and our classification that it's the French classification, which is simpler, allow also to distinguish between typical and atypical form. The atypical form are the ones that are with a lot of variability because they have so many confounding factors. And I think that all this knowledge will contribute to successful clinical trial. My perspective, I think we're gonna find something in the next 2 years. But then to cure the disease, we will need a little bit more, you know, we can improve the disease or stabilize the disease. But to have a cure, I think it's going to be a long journey to find the cure.
Okay, so we don't have questions in the tool, so I think that we are about to finish. It was a very lively discussion and a presentation that clearly kept people thinking. So what else can you ask for? So thank you very much to both of you and to all the participants, and I hope we'll meet again very soon. Okay, bye now.
Thank you, Antonio.